Okay, let's unpack this. We usually think of pregnancy implantation happening, safely inside the uterus where a baby can grow.
Mhm.
But what happens when that implantation goes wrong right at the start and the pregnancy decides to set up shop somewhere else?
Well, that misplaced implantation is pretty much the definition of an ectopic pregnancy, literally means out of place.
Right.
And while it's estimated to occur in, well, a significant number of pregnancies, maybe around 1.3% to 2.4%, according to one source,
Hmm.
the vast majority, something like over 95%, happen in the fallopian tubes.
But the sources you've brought today, they dig into these much rarer and often, well, much more dangerous locations.
Uh-huh.
We're looking at pregnancies that implant in the scar tissue from a previous C-section or in this tiny but critical section of the fallopian tube that's actually embedded within the wall of the uterus itself.
Exactly. We've got these case series looking specifically at cesarean scar ectopics and interstitial pregnancies, plus another source on medical management that gives us detail on one key treatment approach.
So the mission here.
Yeah, our mission in this deep dive is really to draw directly from these cases, to understand what makes these specific types of ectopic pregnancies so challenging, how doctors actually pinpoint their location and the diverse strategies they use to manage them. It's often navigating this complex balance of risks and a patient's hopes for future pregnancies.
Okay, so just to quickly ground us, beyond the main fallopian tube location, what generally puts someone at risk for an ectopic pregnancy? And what are the sort of classic symptoms?
Well, the sources list several risk factors.
Yeah.
Things like having had a previous ectopic, prior surgery on the fallopian tubes, including sterilization,
Okay.
infections like STIs or pelvic inflammatory disease, PID, pelvic adhesions using assisted reproductive technology like IVF, smoking, and even exposure to DES in the womb.
Right. And the symptoms.
The classic signs are usually abdominal or pelvic pain, typically with a missed period, and sometimes vaginal bleeding early on.
Oh.
But as we'll definitely see, the way these rarer types present and the urgency,
Hmm.
well, that can differ quite a bit.
Let's start our deep dive then into those specific locations. Interstitial pregnancy first. Where exactly is the interstitium and why is implantation there so uniquely risky?
Okay, so the interstitium is the very first part of the fallopian tube, the section that's actually within the muscular wall of the uterus that muscles called the myometrium.
Right, the myometrium.
Sometimes it's also called a cornual pregnancy because it's right there in the uterine horn, the corner.
Yeah.
Now, while it's surrounded by thick uterine muscle generally, the critical issue, and the sources really highlight this, is that the thin layer of myometrium right around the gestational sac itself, well, it's often less than 5 millimeters thick.
Ah, okay, so it's the thinness of the wall right there that's the problem, not necessarily the muscle nearby.
Precisely. That thin wall, combined with the really rich blood supply in this specific area of the uterus, creates a very high-risk situation. These are rare, mind you, making up only about 2–4% of all ectopics according to one source, but they are disproportionately dangerous.
How disproportionate are we talking?
Well, one source states they account for almost 20% of all deaths from ectopic pregnancy.
Wow, 20%.
Yeah, with a mortality rate cited at 2.5%. The risk is catastrophic hemorrhage if that thin wall ruptures, because it's just so vascular there. And unlike a typical tubal pregnancy, this location doesn't have that protective layer of peritoneum, the lining of the abdomen. That might slow bleeding down temporarily.
That really underscores the urgency, doesn't it? Are there specific risk factors just for interstitial pregnancy?
Yes, actually. One source notes that having had the fallopian tube on one side removed previously in ipsilateral salpingectomy seems to be a unique risk factor for an interstitial pregnancy developing on the remaining side.
Huh. Okay. So how do doctors use ultrasound to tell if it's an interstitial pregnancy? What are they looking for?
There are pretty specific features. You typically see an empty main uterine cavity, first off,
Hmm.
then a gestational sac that's clearly separate from that main cavity and at least 1 centimeter away from the outer edge of the uterus. And there's that thin myometrium layer we talked about, less than 5 millimeters surrounding the sac. And a really key sign is something called the interstitial line sign.
The interstitial line sign, what exactly is that?
It's basically a thin echogenic line. Echogenic means it looks bright on the ultrasound.
Right.
That you can see extending from the endometrial cavity, the lining of the main uterus, out towards the gestational sac sitting in the interstitium. It sort of represents the connection of the main uterine cavity lining to the tube, basically pointing right to where the pregnancy is located abnormally.
I saw one source also brought up something called angular pregnancy. How is that different? Sounds kind of similar.
Ah, yeah, that's a really important distinction to make. Because the location sounds close, but the prognosis is quite different. An angular pregnancy implants in the lateral angle of the uterine cavity, where the tube enters. But critically, it's within the main uterine cavity itself, just sort of off to the side.
Okay, so it's in the main cavity, just in the corner.
Exactly. And the key difference is that while it's an atypical implantation, an angular pregnancy can sometimes continue to term and result in a live birth. Although, with higher risks of complications like uterine rupture during pregnancy or labor, interstitial pregnancies being located further out, actually in the myometrium, well, they're much more prone to rupture early and are generally not considered viable in that location. Recognizing that difference, it changes everything about how you manage it.
Okay, so interstitial. Rare, very high risk, distinct ultrasound signs, and often needs pretty urgent intervention. Now, let's shift gears to the other specific type in these sources, cesarean scar ectopic pregnancy, or CSEP. This one feels more, I don't know, directly linked to modern medical trends.
It absolutely is. A CTAP is when the pregnancy implants directly within the muscle or sometimes the fibrous tissue of a previous C-section scar,
Right.
usually in the lower part of the uterus. And yes, one source directly links the increasing incidence of CS globally to the rising rate of C-sections.
So as C-sections become more common, we're just seeing more of these. Is that the idea?
That's certainly what the data suggests. The incidence rates cited in the sources, they vary a bit, but somewhere from 1 in 800 to 1 in 2,500 of all ectopic pregnancies. Or, put another way, making up about 6.1% of all ectopics.
Still rare, but maybe not as rare as interstitial.
Relatively speaking, yes. It also seems to have a recurrence rate of around 5% if it's not managed properly the first time. And there's still a mortality risk cited at about 1 in 500 cases.
Still a significant risk then, beyond just having had a C-section. What are the other specific risk factors for CS? Does anything else increase the odds?
Yeah, the sources mentioned several things. Poor healing of the original C-section, incision, obviously, but also any prior hysterotomy that's a surgical cut into the uterus for other reasons, things like a DNC, dilation, and curettage.
Okay.
Other uterine surgeries like removing fibroids, that's myomectomy or hysteroscopy, even manual removal of the placenta after a previous delivery. And interestingly, a higher incidence is reported after IVF pregnancies.
That is interesting about the IVF link. And what about the point you made earlier that the number of C-sections doesn't necessarily correlate to the risk?
Yes, one source specifically noted that. The risk for CSF doesn't seem to directly increase with the number of previous C-sections someone has had.
So it's not like having 3 C-sections makes you much higher risk than having 1.
Apparently not necessarily, which is surprising. It suggests maybe the quality of healing of that first scar, or perhaps other underlying uterine factors, might be more influential than just the number of procedures. It's a complex detail.
How is CSEP diagnosed? Ultrasound again?
Yes, ultrasound is definitely the primary tool here too. You'd see the gestational sac positioned right at the site of the prior C-section scar and clearly outside the main endometrial cavity.
Outside the main lining.
Right. And there's often a very thin, or sometimes even absent, layer of myometrium between the sac and the bladder, sometimes only 1 to 3 millimeters thick.
Wow, that's thin.
Very thin. The cervical canal should also look empty. And if the ultrasound view is difficult or unclear, MRI can be used for better visualization.
Okay. And I think the sources mentioned different types of CSEP based on how they look on ultrasound.
That's right. They describe 2 main ways CSFs can present, and this actually helps guide management. Type I seems to progress somewhat towards the uterine cavity, while type 2 shows deep infiltration into the uterine muscle and towards the outside surface of the uterus.
And type 2 is the riskier one.
Yes, type 2 is generally considered much higher risk for rupture and severe hemorrhage because it's growing outwards, potentially breaching the uterine wall.
So, okay, both interstitial and CSEP are rare, definitely high risk, and rely heavily on those specific ultrasound findings for diagnosis. Given these risks, how do doctors actually decide on the best way to manage them? The sources really emphasize there's no single standard treatment.
Exactly. For both of these conditions, because of those potentially life-threatening risks like hemorrhage and uterine rupture, the main goal of treatment is therapeutic termination of the pregnancy to prevent those outcomes.
Right. Makes sense.
The challenge, as you noted, is deciding the method of management. There really isn't a single standard approach, and the choice has to be highly individualized for each patient.
What kinds of factors go into making that decision then?
Well, the sources list several key things. First, the patient's overall clinical condition critically. Are they stable? Is there active bleeding?
Okay, stability first.
Absolutely. Then was the diagnosis made early? What's the size of the pregnancy sac and how far along is it? For CSP specifically, that ultrasound type I versus type 2 is really crucial. Beta HCG levels, the pregnancy hormone level, are very important. And then critically, does the patient desire to preserve their ability to have future pregnancies? That weighs heavily.
Right, the fertility aspect. Let's look at medical management first, particularly using methotrexate, which one source covers in quite a bit of detail. What exactly is methotrexate and how does it work here?
So methotrexate is a medication, a drug, that basically blocks the action of folic acid in the body.
Folic acid, like in prenatal vitamins.
Exactly. Folic acid is absolutely essential for cell growth, particularly rapid cell division. And of course, a developing pregnancy involves extremely rapid cell replication. So methotrexate is highly toxic to these rapidly dividing cells. It effectively stops the pregnancy from developing any further.
Okay, so who is actually a good candidate for this medical management approach with methotrexate based on these sources?
The eligibility criteria are pretty strict, and for good reason, because of the risks involved if it doesn't work or if something goes wrong. The patient absolutely must be hemodynamically stable, meaning their blood pressure, heart rate are normal, they aren't showing signs of significant internal bleeding.
Stable, got it.
They shouldn't have severe or persistent abdominal pain, which could signal impending rupture. They also have to be willing and able to commit to very close follow-up, sometimes for weeks.
That's a big commitment.
It is. Generally, the gestational sac size needs to be relatively small. Typically, the cutoff is mentioned as less than 3 or 4 centimeters. And crucially, especially for interstitial pregnancies, where viability is sometimes a question early on, there should ideally be no fetal cardiac activity detected on ultrasound.
No heartbeat.
No heartbeat, indicating it's not viable. Serum beta HCG levels are another key factor. They typically need to be within a certain range, often less than or equal to maybe 5,000 to 10,000 MIU/mL, though the exact cutoffs can vary slightly between guidelines or sources. And they need normal liver and kidney function tests because the drug is processed by those organs.
The cases you mentioned really help illustrate this. Like in the interstitial pregnancy series, case 1 was successfully treated with just a single dose of systemic methotrexate, right?
Yes, exactly. She basically met those ideal criteria perfectly. She was stable, her HCG level was low, the mass was small, less than 4 centimeters. No free fluid seen in the abdomen on ultrasound, no cardiac activity. And importantly, she strongly desired future fertility, which medical management generally offers a better chance of preserving compared to some of the surgical options.
And the source looking at general ectopic pregnancies, not just these rare types, also showed success with methotrexate in multiple cases.
That's right. They described 6 cases that were successfully managed medically. These patients also fit that profile: stable, diagnosed relatively early in gestation, no cardiac activity, and HCG levels generally within or closely monitored around that recommended range. And what's really powerful about following those cases is that 2 of those patients later went on to have successful full-term pregnancies.
Wow.
Yeah, so it really demonstrates that fertility preservation benefit in practice, which is a major plus for this approach when appropriate.
And case 3 in the CSEP series was also treated medically.
Correct. She was diagnosed very early, around 5 weeks gestation, and had a lower HCG level, making her a suitable candidate for trying that less invasive approach first.
So what does the follow-up look like after someone gets methotrexate? You said it requires commitment.
It's really important, yes. Patients are monitored closely for any new or worsening symptoms, like increased pain, which could mean rupture, and their plasma beta HCG levels are checked weekly. This is crucial to make sure the levels are declining appropriately, showing the treatment is working.
How long does it typically take for everything to resolve, for the HCG levels to go back to normal?
Well, the source on general ectopics mentions it can sometimes take 6 to 8 weeks if the initial HCG levels were very high. But the average resolution time in their case series was around 30 days, about a month.
Okay. And what happens if the HCG levels don't drop like they're supposed to after that first dose?
Yeah, that's a sign the treatment might not be working fully. The sources discuss specific criteria for potentially needing a second dose of methotrexate. For example, if the HCG level doesn't drop by at least 15% between day 4 and day 7 after the injection.
Okay, that specific drop.
Right. Or sometimes they look at whether the level on day 7 isn't significantly lower than day 0, or maybe still above 85% of the day 4 level. If those criteria aren't met, a second dose might be given. This actually happened in some of the cases in that general ectopic series.
Are there any lifestyle things patients need to be careful about while they're undergoing methotrexate treatment?
Yes, because it's a folic acid antagonist, the sources specifically mention avoiding alcohol. and also avoiding supplements or even foods that are high in folic acid, because that could counteract the drug's effect.
Right, makes sense. So the advantages of medical management seem pretty clear then. It's less invasive, potentially less expensive, and offers that better chance of preserving fertility.
Absolutely. Those are the big draws. But the sources are also careful to highlight the downsides. It requires really strict patient compliance with that follow schedule for potentially several weeks. And there's still a persistent underlying risk of rupture while you're waiting for the pregnancy to resolve, even if it's lower than if it were left untreated entirely. You're not completely out of the woods immediately.
Which brings us then to surgical management. When is surgery the necessary approach?
Right. Surgical management is really considered the standard of care in situations where the patient isn't stable, where there's a strong suspicion or even confirmation of rupture, or when medical management just isn't appropriate for various reasons, or if it's been tried and has failed.
And if there's a rupture, you said that's an emergency.
Absolutely. If a patient is hemodynamically unstable, low blood pressure, fast heart rate, signs of significant internal bleeding, urgent surgery is potentially life-saving. Case 2 from the Interstitial Pregnancy series is just a stark example of this.
Remind us about that case.
She presented with acute, really severe pain, dizziness. She was clinically unstable. Her blood pressure was low. And the ultrasound showed free fluid in her abdomen, which strongly indicated significant bleeding internally.
Right.
She required an emergency exploratory laparotomy, that's open abdominal surgery, and what's called a corneal resection, where they surgically removed the affected part of the uterine horn containing the ruptured pregnancy. That surgery was absolutely critical to control the hemorrhage and save her life.
Wow. Okay. So emergency open surgery for unstable rupture. What about surgical options for patients who are stable? Perhaps where medical management wasn't a good option or it didn't work, but they still want to try and preserve fertility if possible.
Yeah, that's where things get interesting. The sources describe various less invasive surgical techniques being used in carefully selected stable cases. These procedures aim to remove the pregnancy tissue while minimizing the impact on the uterus and fallopian tubes, hopefully preserving function.
Okay, so for CSEP, what are the different surgical approaches mentioned in the sources?
They list several possibilities. There's vaginal hysterotomy, hysteroscopic resection, laparoscopic resection, and then laparotomy with wedge resection.
Okay, let's maybe clarify those a bit. Vaginal hysterotomy, that's accessing the scar through the vagina somehow.
Yes, exactly. Going through the vagina to reach the scar area surgically. Hysteroscopic resection involves using a hysteroscope, which is a thin camera inserted through the cervix into the uterine cavity
Right.
to try and visualize and remove the tissue. Though, as we discussed, this can be tricky because the pregnancy isn't really in the main cavity. Laparoscopy uses small keyhole incisions in the abdomen with a camera and specialized instruments. And laparotomy, again, is the traditional open abdominal surgery. A wedge resection just means removing a small wedge-shaped piece of the uterine muscle that contains the pregnancy.
And the sources mention that DNC isn't usually effective for CSEP. Why is that again?
That's a really critical point they make, and it goes right back to the location. A DNC involves scraping the inside lining of the main uterine cavity. But because the pregnancy in CS is embedded outside that cavity, within the scar muscle itself, a standard DNC often just won't reach the pregnancy tissue effectively. So it's considered to have a doubtful role and could potentially even cause more harm, like perforation or increased bleeding, without actually removing the ectopic.
That makes perfect sense when you think about the location. What about the risks involved with these CSEP surgeries, even the less invasive ones?
A major risk that's highlighted across the board is massive hemorrhage. Removing tissue from that scar site, which can be quite vascular, can lead to really severe bleeding. Sometimes it's so significant that it necessitates an emergency hysterectomy removal of the entire uterus as a life-saving measure, even if that wasn't the initial plan.
Wow, okay, so that's always a possibility.
Right.
Are there limitations to when you can use the less invasive approaches for CSEP, like laparoscopy or hysteroscopy?
Yes, definitely. One source specifically advises against attempting laparoscopic or hysteroscopic resection if the thickness of the myometrium remaining between the gestational sac and the bladder is very, very thin. They've mentioned specifically less than 3 millimeter.
Why is that?
Because the risk of inadvertently injuring the bladder or the ureters, which sit right there, during the procedure becomes much higher when that tissue layer is so thin. So in those higher risk type 2 CSFs, the ones growing outwards or where uterine rupture is suspected, laparotomy, the open approach, is often preferred because it allows for better control of potential bleeding and better visualization of the anatomy.
Okay. And shifting back to interstitial pregnancies, if methotrexate isn't suitable or doesn't work, but the patient is stable, what less invasive surgical options are discussed for that location?
For stable interstitial cases needing surgery, the sources mention procedures like laparoscopically assisted transcervical suction evacuation. That means using vacuum aspiration like a DNC instrument, but guided by a laparoscope looking from the outside for visualization and safety.
Ah, so using the camera to guide the suction.
Exactly. And also hysteroscopic guided removal is mentioned, again trying to use visualization from inside or outside to remove the pregnancy tissue with potentially less impact than doing a full corneal resection, which removes a larger piece of the uterine horn.
And we have cases from the sources illustrating these different surgical approaches too, right?
Yes. Case 1 in the CS subseries, for instance, was managed with laparotomy, the open surgery, while Case 2 used laparoscopy, the keyhole approach.
Suggesting maybe case 1 was more complex or advanced?
Likely, yes. And then from the interstitial series, Case 3 was managed with hysteroscopy, followed by vacuum aspiration. She apparently elected this option after counseling on all the risks and benefits.
And case 4 from that interstitial series, the one that had a viable fetus.
Yes, that was a particularly challenging case. She underwent vacuum aspiration, but it was done under laparoscopic guidance. The laparoscopic visualization was chosen specifically to assist the vacuum aspiration procedure, deemed the most suitable approach in her specific situation to try and preserve her future fertility while giving the surgeons direct sight during the removal process, which is riskier when there's a viable pregnancy.
So it really sounds like even with these less invasive surgical techniques, significant risks are still very much present.
Absolutely. The sources are very clear on this point. Even when attempting these less invasive fertility-sparing procedures, patients absolutely must be thoroughly counseled about the ongoing risks. Risks of significant uterine bleeding, potential uterine rupture during or after the procedure, and the definite possibility that the procedure might need to be converted unexpectedly to an emergency laparotomy or even result in a hysterectomy if serious complications arise.
Okay, let's try and connect all these threads now. Pulling it together, one of the really key takeaways from this deep dive into the source material on these rare ectopics.
Okay, yeah, let's summarize. I think the critical insight really is that while ectopic pregnancy overall is relatively common, these specific implantations in C-section scars or the uterine interstitium, though much rarer, represent a distinct and pretty significant clinical challenge. They carry potentially life-threatening risks if they're not identified and managed rapidly.
And early diagnosis is absolutely crucial. We saw that again and again. And it relies so heavily on specific ultrasound findings, which are quite distinct for each location.
Yes, exactly. And the management is highly individualized. It's definitely not a one-size-fits-all decision. It really depends on the patient's immediate stability, the pregnancy's characteristics, its precise location, size, viability, and very importantly, the patient's goals regarding future fertility.
Medical management using methotrexate seems to be an increasingly important option, but only for those carefully selected, stable patients. It offers a less invasive path and definitely a better chance of preserving fertility down the line.
For sure. But surgical intervention, ranging from those less invasive procedures we discussed all the way to emergency life-saving open surgery, remains absolutely essential for unstable patients, for those with rupture, or in cases where medical management just isn't appropriate or hasn't been successful.
And a really vital caution that came out of one source is that subsequent pregnancies, after someone has had a C-sep treated, carry their own increased risks, particularly uterine rupture during that next pregnancy. So they require very careful monitoring.
Yeah, which really raises an important question for the future.
So what does this all mean for you, our listener? These case series, they really provide a window into the complexity doctors are facing every day. They're balancing this need for urgent, sometimes drastic treatment with the very delicate possibility of future pregnancies for their patients. As C-section rates continue to climb globally and as assisted reproductive technologies become more widespread, are we inevitably going to see more of these really challenging ectopic pregnancies?
It seems possible, doesn't it?
And how will medical science continue to innovate and refine that difficult balance between effectively treating these rare high-risk conditions and preserving a woman's ability to potentially have a healthy pregnancy in the future?
It's definitely a field where ongoing research and, importantly, the lessons learned from individual patient cases, just like the ones described in these sources, are continuously shaping and improving clinical practice.
Thank you for joining us on this deep dive into this really challenging but critical area of reproductive health. We hope it's given you a clear understanding of these rare conditions and the complexities involved in managing them.